Before I start, I'll pay my appreciations to welcome all of you. And of course, you have seen all these three guns blazing. Absolutely. I have never seen people talking from directly to heart talk, what is we call it as. And I genuinely started believing that how convinced and how lucky we are to have these gentle giants sitting, and we are going to discuss about the practical problems that we are going to get, or probably are anticipating, or now we already have started getting it, and now we are seeking the questions and the answers to our questions. So before I start my panel discussion, I welcome once again Dr. Sunil Gupta, the President-elect of RSSDI. Put your hands together for that. Dr. J.J. Mukherjee and Dr. A.K. Singh. Wish you all a very, very happy Dashera, or what we call it as a Shubha Vijaya Dashmi, right? Correct. Shubha Vijaya, right? Thank you very much. And this session is with the educational partnership with Novo Nordisk. So thanks this team also. So the first question that came to my mind when I was listening to Sunil and when I was listening to JJ was this, that yes, this is for Dr. Sunil Gupta. I have decided to put this patient on with SEMA, fine. And now I have injectable SEMA once in a day, 2.4 milligrams. According to who are those people, those who actually call for the initiation of SEMA? Who are the right kind of the people whom definitely will initiate or explore the possibility of initiation? Can you put on his mics, please?
I feel, yeah, audible? Yeah. So I feel things are very much streamlined as far as recommendations are concerned. So authorities have given the recommendation that someone who has BMI of more than 27, and if they have some associated one of the comorbidities, in such patients you can certainly use semaglutide, and those who have BMI of more than 30 without comorbidities, they can be used, they can be the right candidate. And of course, this particular molecule has also shown its benefit in the CV outcome trials now after the SELECT trial, and that is why now there are newer indications that these patients are supposed to be put on such drugs.
But do we follow the same thing as far as the Indian population is concerned also, or do we have some different Indian cutoffs?
Now,
and I would request both other faculties also, so AK and JJ, both you can barge in wherever you feel that you need to speak.
Till this moment, we have the same recommendation which is there globally, but there are some trials which has happened in, I feel, step 11, which was in Bangkok and some other Asian countries, and they have used 23 to 25 also in this trial. So at this moment of time, the recommendation says, and we have to follow that.
Perfect. So thank you for that. Now my next question is to Dr. J.J. Mukherjee, sir, is how do you titrate? And suppose I suppose decide to initiate. So how would I go about it? Straightway jump to 2.4? Then what we can do?
So there are two groups of patients. Ones who are already on a GLP-1 RA, maybe liraglutide, dulaglutide, or
Correct.
maybe oral semaglutide.
Correct.
And they want to change. And there's some other group of patients who have never been on a GLP-1 RA. So if you are using it in somebody who's never been on GLP-1 RA, essentially people with obesity without type 2 diabetes, I mean, as the slide says, always start with 0.25. Don't rush. I have rushed before with other GLP-1 RAs, and I've tried with SEMA 2.4 and I've miserably failed. So I'm telling you from my experience. Start 0.25, go for 4 weeks. Tell the patient with 0.25 they may not see the benefits as so soon. Some people do lose with 0.25 as well. Then go to 0.5, 4 weeks. Then go to 1 for 4. So there are 5 doses. The 5 pens are there, and each pen has got 4 doses. So once a patient buys a pen of 0.25, he or she is committed to take 4 doses, because otherwise the money goes waste. So they need to prime the pen once, and then they inject weekly 0.25 4 weeks, 0.5, 1, 1.7, and then go to 2.4. If somebody is already on a GLP-1 RA, somebody like say obese type 2 diabetic patient, then suppose somebody is taking oral semaglutide, say they could tolerate up to 7 milligrams. There's no guideline here. I mean, I think 3 of us might disagree. You will soon hear of this.
We'll hear that from AK as well.
I start with 0.5 and then I go up to 1. I'm not bold enough. If somebody's on, say, oral semaglutide 14 milligrams
Yes.
and tolerating it quite well, but hasn't lost the weight, has got good glycemic control, but hasn't lost the weight, there I offer them injectable semaglutide. There I might be happy to start with 1 milligram straight away.
Straight away.
Straight away. Somebody in dulaglutide 0.75, I'll go with 0.5. 1.5 doing well, I will go with 1 milligram. But this is, as I said, people on GLP-1 and ones without GLP-1.
AK, what is your take on this?
Yeah, so he's right, absolutely. So that should be the consideration. If patient is already GLP-1 primed, as Dr. JJ said, you can, unfollow the classical rule, and you can say, for example, as he said, if you are on 14 milligram oral semaglutide, that has got at least data.
Yes.
14 milligram is equivalent to 1 milligram
1
of
milligram,
semaglutide.
yes.
So if your patient is in ribalsis, he wishes to lose further weight, you can shift them to 1 milligram directly, no need to go back to 0.5, 0.25, 0.5 and then 1. Straightforward you can go, start batting from the 1 milligram onward.
How-
Exactly, Dr.
how-
JJ said.
But how easily you feel that in Indian subclass of the patients we are able to reach the dose of 2.4?
Well, so at the moment, see, we all have started using recently, for example, my patients, only few patients has reached to 2.4 milligram at the moment, because for the 2.4 milligram to go, you have to go at the 5-month interval.
Correct.
Semaglutide has not come within a 5 months. So our patients right now, for example, my majority of patients are right now in the 1.7 milligram. Some of them has gone to 2.4, hardly 2, 3, but majority of them are 1.7 at the moment. So they are tolerating. I can tell you that I thought that they would not tolerate. So maybe I have got a little different regime from the classical textbook reading, because I advise my patient that if you feel any nausea and vomiting, don't step up the dose. You continue with the next pen. So example, if your patient is on 0.5 milligram and developed a nausea and vomiting, I step down to the 0.25, then I continue with the 0.5 later on for not 1 month, for the 2 months.
2 months,
And
yes.
then easily he catch the 1 milligram.
Correct.
So losing weight is not a one-day game.
Yes.
Don't lose the match.
Yes.
Don't go and make 6, 3, 6 and get out in a test match. You have plenty of time to lose weight.
Costing me money, sir.
Yes.
Yeah, that's
Awesome.
there.
And absolutely, you are right.
You cannot be a Salman Khan without, losing your money. As simple as that.
Importantly, when we talk about tolerance, it's the diet which plays a major role.
Correct. So we are going to come to that, Sunil, in our discussion. So friends, we have a wonderful pen. How many of you started using the SEMA? Just show me of hands. Yeah, some hands going up. I'm happy, but still.
Mangesh, the last line is very important.
Yes, that's what I was saying.
Because no, this is exactly like insulin, you see. Insulin we store in the fridge, but once you start using a pen, I tell my patients, they need not put it back in the fridge.
Correct.
Patients do that. Because for 28 days, and there's a study from Vellore, up to 35 days, your insulin is stable if it's kept at room temperature. Same if you see the last line with semaglutide. If you have bought 2 pens, then you have to keep the other pen 2 to 8 degrees, but the pen that you're using, you can keep it outside. No need to put it back
For
in the
6
fridge.
weeks, and that too.
For 6 weeks.
6 weeks.
Just I will add one point.
Yes.
For semaglutide, for Wegovy injection, at least you have got a liberty that either you can keep on a room temperature or you can put it back on the refrigerator's door.
Right.
But for the Monjaro, you should not put it back on
Back-
the refrigerator.
yes, yes.
That point must be learned.
That must be learned.
Once you have taken it out and you have started on Monjaro pen, for example, do not put it back into the fridge.
Correct.
That's the recommendation for the Monjaro pen.
Can you have a big round of applause for that one wonderful practical guidance from EK. So wonderful pen, 5 coded pens we have, easy to use, easy to administer, and genuinely all the points, all the challenges of not only initiation but intensification also are taken very well with this lovely device that comes with injectable Wegovy or semaglutide. And of course, naturally, a genuine practical question once again. Any one of you can take it.
This is
JJ?
basically for me.
Yes,
I think
this is-
answers are straightforward.
Yes. So
patient needs
if
more
I
time
miss,
to.
if I am on with Wegovy and I probably I'm taking it every Sunday and I miss this because of the conference I'm stuck up in, and I take it, I forget the dose.
You have a
of-
window of 5 days.
Yes.
And if you see 1.7 and 2.4, most of the trials are done with what's called MTD.
Correct.
Maximum tolerable dose.
Absolutely.
So 1.7 or 2.4. And
Correct.
patient misses more doses, just like anybody else, go back to class 1, start studying again, start from beginning.
Wild situation, a guess. Somebody suddenly decides to stop it. He or she has reached a dose of 0.5 milligrams, decides to stop it for say 3 months of time, and now wants to reinitiate back. how would I go there?
That's the last line you see. Patient misses
Yes.
more doses, reduce the starting dose for readings should be considered. But again, this is case by case basis.
So
If I had somebody who on 0.5 milligrams for 4 months was doing very well, I won't go back to 0.25 again. I'll
Okay.
start again with 0.5.
So we can continue. We can continue with the same dose. We can try at least. That's what.
See, you have the caveat at any point they are feeling unwell.
Yes.
I mean, not little bit unwell. Everybody will feel unwell when they start.
Correct.
So you tell them the degree of unwellness.
Right.
When they should step down, you see. But everybody, when they start, they will get. I mean, I have had patients who have cursed me. So, क्या दवाई दे दिया डॉक्टर
I
साहब,
swear.
जिंदगी बर्बाद कर दी. But then 3 months, not 3 months.
Generally, for 2 weeks, we are the villains of their life. Then slowly they settle down for sure. Iki, this is for you. Considering the safety profile and all the data that we have, how safe do you feel? As far as you already answered in your beautiful session that you.
So
took
one
it.
liner answer is, although
Yes.
this is very personal,
Yes.
but I don't, want to keep it secret. This is as safe as that I myself is on semaglutide 2.4 milligram.
Correct.
So that is the secret of his weight loss.
That is the secret of my weight loss. So naturally, I need to be convinced on the data. I am not a guinea pig that I will take whatever pharma industry teaches me. Now,
Absolutely.
this is the evidence which has been generated. Remember, semaglutide was approved.
But
in-
I must say you were brave. I think the NAION data was
Right,
not
so
there when you started.
Dr.
No, no,
J.J.
we-
Mukherjee
we-
always used to tell me in
No,
my,
no, you
my
were brave,
ear.
boss. It
Few
wasn't
days
there.
back he told me, boss, take care of NION. I said, don't worry. So I was happy that he presented this
You
data
can
himself.
predict the future. Yeah, you predict my
in fact, JJ, let me tell
We-
you that
we wrote
me and Ike has written an editorial in Japi on the NION.
I saw that, I've seen
Absolutely. Okay, so-
So coming back to the point that, see, semaglutide, the, higher strength which we are seeing right now, semaglutide came and given approval in 2016, 9 years back, after the Sustain 6 trial.
Yes.
Remember, Sustain 6 was the first, this semaglutide, right now I am on 1 milligram, Wegovy right now. So I am taking basically Ozempic at the moment. This was been studied in 9 years back with the mammoth evidence which we have in the form of Sustain 6 flow, and then you add into the semaglutide 2.4 milligrams data through all
Correct.
STAPE trials and the select trials. What else you need? It has got a GI side effect. That's it. This is how it works. I don't feel to eat. Once I go to the lunch counter, just half chapati, I am done. I know this is because of the medicine which I am taking. If now patients party and comes, my wife complains, doctor, what medicine you have given? That my husband is not taking the food. This is how it works.
Yes,
Your husband
absolutely.
took the food for, past 50 years. That's why his BMI is 40.
Yes.
Let him stop for the 40 days. As simple as that.
I'll share an anecdote. It happened with me. I mean, the wife after not 2 weeks, this was not semaglutide, the other one, which came 6 months ago. She opened the door, गाली बकते बकते क्या किया है मेरे सास ने मेरी माँ ने जितना खाना सिखाया सब बनाती हूँ ये बैठते हैं आधा खाते हैं उठ के चले
I
जाते
swear by
हैं.
God.
I had to stop the medication.
So what is the biggest message of the whole thing is that, we Indians are, nowadays extremely foodies, and this food intake is just because the things are available. So it is an hedonic eating that we have. And these drugs like Sema has an effect on your hedonic eating. It reduces down the craving for the food. It reduces down your need to eat. वो by default हाथ जाता है ना सामने जब बैठे हो मीटिंग में तो चॉकलेट्स खा रहे कुकीज खा रहे ये सब चीजें बंद हो जाती है. And this is exactly what happens. So GI side effects, renal protection, maybe probably pancreatitis. One very interesting discussion which was on, and now good question that was, and JJ was the one who was talking about it on one of the groups in the WhatsApp, and I'll just continue. Highlight us on that lactation and the issues which was discussed, and is it safe in the lactating
JJ
mother?
was not there, I was discussing.
Yes, you were. No, not JJ, I'm sorry, AK was discussing. So yeah, JJ was not there. So AK was not convinced about that. So I would like to have your highlight on this.
So it's nothing. We are not supposed to use during lactation. That's what the PA was earlier. So few days back, in fact 48 hours earlier, the Monjaro has got a new level update that you can use it during lactation. So because of that, one study conducted in Monjaro in 11 people, healthy people with lactation. So we were debating that is it sufficient data to use it. I would not be very keen to use these drugs during such a crucial period of time.
Yeah.
Whole life is there to use. People ask me, pregnancy lactation, why you can wait for 6 months.
Yes.
Let your child become healthy and
Yes.
you also remain healthy.
Yes.
If you are not keeping well, because of the GI side effect. If you're not able to eat properly, how can you feed your baby? As simple as that. See, once you are on a GLP-1 or GLP-1 GIP, you lose weight. You also lose lean muscle mass. Let me tell you, in myself, I lost lean muscle mass. I have stopped taking, Wegovy for 1 month. I gained 1 kilo weight. I wanted it. I am experimenting on myself.
Yes.
To look, I measured that, my muscle bulk has gone down. It does, cause some kind of
regain is not muscle up.
so because I'm not, nobody knows about that. Nobody knows about that.
Data as of now, the regain,
Yes.
what muscle you lost, you lost.
Right. So so that's not very clear. So people are debating that if you lose muscle, can you regain muscle? Because I'm continuing on
You
that.
can have more protein. do
Because
little-
that's the reason.
Do
Because I'm
exercise
continuing my
and-
exercise, I'm taking on that particular diet. Having said that, in the context of lactation, I don't think it is pragmatic. Let's hold everything for some time.
Yes.
And then there's no, you can discuss it theoretically, but it is not practicable.
Point very well taken. A very interesting question has come to me, JJ, and I was really confused when this term was used as, what is a food noise? So, effect on the food noise. So, first tell us what is this bloody food noise means.
It's very
to me.
interesting. You see, Avdesh will tell you that in idea group, whenever you have meeting, I always use this word noise.
Noise, yeah.
So it's poetic that this question has come to me.
Yes.
Food noise is this, kind of obsession with eating. All pervasive thought that you want to eat. Talk to people with obesity, they will tell you, doctor, I don't want to eat, but I can't help it. This thought keeps coming, the chocolate in the fridge and the ice cream that I bought the other day, the thought keeps, you and I maybe we don't have. Anybody in this room has food noise?
Everybody has.
Anybody in this room has food noise?
Everybody
Raise your
has.
hand. Food noise
You
means
are the-
खाने को दिल करता है हमेशा. अभी lecture सुन रहा हूँ लेकिन मन में कि बाहर जाके एक थोड़ा coffee और biscuit खा लेने का है.
Yes.
Anybody in this room is thinking that?
Yes.
Then raise your hand. Then you're having food noise. So yeah, and be honest. I get food noise. I'll tell you when I get food noise. All my studies I do, both Abdesh and I actually, from 11 to 3 in the morning. So those 4 hours, I get so much food noise. I read half the paper, I go into the fridge, open, कुछ नहीं मिला तो chocolate रखा बच्चों का वो खा लेता हूँ. So that's a all pervasive thought of eating. Obsession. That's called food noise. That's what it says. Persistent, unwanted thoughts of craving for food. Impact on life, it affects food choices. It basically disrupts your mental health. You may not be able to relate with it, but next time you see an obese patient, especially a lady, happens with ladies more. People with depression, they get this. What's a part of the weight gain in depression is the drugs, they lack exercise. Part of it is food noise. Because whenever they feel too sad, they go to the fridge and eat. Clinical recognition is basically,
Yeah, so
this I did not know.
Yes, but this needs to be recognized clinically.
is recognized as a
Yes,
inverted commas,
yes,
the
as
criterion to
very,
look at.
very important. And this was a survey, very interestingly, and you can talk through us, JJ, about this.
This was, as you can see, the footnote there.
Yes.
It was just presented about
Yeah,
2
this
weeks ago in
EASD,
Vienna.
we were all there in this
So
when this was
prior to
presented.
this hedonic eating, we say, hedonic eating. See, there are 2 ways we eat, human beings. There's physiological eating, which is controlled by your hypothalamus. You have a hunger center, you have a satiety center. If all of us, like animals who live in the wild, if we live like that, we won't be obese. You don't see an obese lion or obese tiger in the jungle. You see them in the zoo.
Yes.
Because they're again fed. They're having hedonic eating. But we humans have hedonic eating. We eat. So this trial was done. Now these trials I find always very hard to believe. They're questionnaire trials. But having said that, psychologists will shoot me for saying this. These are very well-designed questionnaire trials. They're very well validated. And you see, now, can you make out the difference? The first point they asked was constant thought about food throughout the day. Now, how many of you in this room have you asked yourself? Excessive thinking about food. Then, feelings of uncontrollable thoughts about food. I don't get that. Negative impact on food thoughts, I don't get that. And interactions of food-related thoughts with daily functioning. I think most of us in this room are not in that morbid obese category. Avdesh said all of us are obese, but I don't see 35, 40 here. आप 28 के हो. So we don't have 30, 35, 40. Once you see these people, 35, 40, 45 BMIs, they have this problem, unfortunately.
And look at the results. This was presented on 17th of this last month, in the oral presentation there. And look at the amazing benefits that you are getting. 46% reduction in the food thoughts. You don't feel like eating. Self-control is far better. You are less obsessed. And ultimately what it boils down to is a wonderful satisfaction. So you don't feel like eating again. And that continues. So you know,
Mangesh, this is basically the proof about semaglutide works
Yes,
on the
yes.
hedonic eating part.
And that's the
I
reason
used
why,
to say it.
why probably, you know, Avdesh is loving it, you know. I say that now. Hardly any drugs you will see Avdesh.
Let me share you one story of my own house. So
Yes.
my wife is a Punjabi lady. So when I go to my in-laws place, I gain 5 kilo body weight, not because I am the son-in-law, because this is a typical Punjabi's family's food habit. Everywhere they put
Ghee
Punjabis
and
protest.
so butter.
Butter
No, that's
and ghee
in a
and-
loving way. So every morning my wife used to say, so what you would like to have? So, aloo paratha. Okay, so that paratha word every day comes into picture. Now seeing that I am on now semaglutide and I lost 8 kg, she also started taking it and she lost 10 kg now. And she never asked me now that would you like to have a aloo paratha in morning? So that's a food knowledge in my own
So we
family.
have stopped going to Abdesh's house now. वहाँ आलू के पराठे मिलते हैं।
That was lovely. Sunil, this is for you. As far as safety, Avdesh has briefed us beautifully well, but little pearls of wisdom when you talk about safety profile of SEMA. And here I would be very specific on pancreatitis, one which we did not discuss adequately. So give us your views on this and talk us through this.
The evidences with, just go back to the previous slide. The question says, what is the evidence with regards to
Safety profile of,
semaglutide?
yes, yes.
I feel we have the evidence as Dr. A.K. Singh here sitting.
Yes,
So
yes, that is the biggest evidence.
That's the biggest evidence. At
Real
this point
world
of
and that-
time. This is a real world. But of course, we know that we have multiple trials which have been conducted in this. We have people with cardiovascular disease without diabetes, knee osteoarthritis, renal impairment, NASH. We have just heard about one of the trial, and then we have that. Then we have obesity in heart failure with preserved erection fraction and type 2 diabetes. Adolescent, elderly population also they have some data, as well as in pre-diabetes and remission. And type 2 diabetes. So they have multiple data, and you have seen the SELECT trial, you have seen the STEP trial, and they have all shown multiple, an ESSENCE trial, if I'm not wrong, the name NASH trial is ESSENCE trial. So you have the data available as per as their efficacy in various situations which is concerned, and they are all beneficial, and the SELECT trial is the only as till date, as the JK says. So till date we have the trial which says that it has shown its benefit from 20th day onwards. The lines got separated from the very early stages of the initiation of the drug. So you have the CV safety data, except the GI side effect, and you have the patient population. If you see, more than 60,000 participants in all these trials, and cumulative exposure of more than 33 million person a year globally. And Indian
Unbelievable.
population
This
also
is-
we have 3,700 patients.
I think
and
Avdesh was-
sustainability effect is more than 4 years.
Avdesh
So
was
it's-
so
it's-
right
it's-
as far
yes.
as the robustness
except
of
those,
the
small,
evidence that we have as far as this drug.
And if you see the
In
withdrawal,
fact, we need to
because of the-
appreciate this. In
Yeah.
fact, every one of us need to appreciate the amount of the evidence that this molecule has.
And importantly, if you see the discontinuation rate is just 4.3%,
Absolutely.
and 83% have continued it. So small GI side effect which every GLP-1 analog will have, you have to, I feel, one of the good molecule, and one should accept.
Yes, I will just add into a
Yes.
simple story.
Yes, yes.
So semaglutide doesn't mean that Wegovy. Semaglutide starts from the sustained semaglutide.
yes.
That is Ozempic.
Ozempic, yeah.
So we had, let's not forget, 11 sustained trial done. 11 with Ozempic. 11 step trial done with Wegovy. So 22 trial. In teens, step teens trial, 24th trial. Then you have got a cardiovascular outcome trial, SELECT, 25th. 2 heart failure trial, 27th. MSLD trial, 28th. What else? Stride, flow, add. 30 randomized control trial. People say, boss, कुछ लेने से होगा तो नहीं.
Absolutely.
मैंने बोला रास्ता पर बाहर निकलने से सामने वाला
But
गाड़ी ऊपर
can
से
I
चला जाएगा.
can I
बात
give a
खत्म.
dissenting note here?
Yes.
I'll give a little bit dissenting note.
Yeah.
I mean, it's not that good a molecule. There are quite a number of people who cannot tolerate it, boss. Let's accept it.
Yeah.
If you take the
Yeah, so that is what exactly. So,
don't
so what are
brush-
your tips now? We
no,
know
wait,
that.
Don't brush that GI side effects are mild to moderate.
Yeah.
There are people who get really severe GI side effects and they have to stop.
Yes.
All the trials.
Yes, yes.
It's 4.3 is not the right data. Not
Yeah.
only 4.3%. In select trials, 16% people stop.
Yes.
Because of GI side effects.
Yes.
So don't just put it under the carpet.
But do you feel that this is
It is not a life-threatening
do
side
you
effect.
feel so? My question is, do you feel that this has to do with the duration? So more shorter acting drug, the GLP, you get more GI side effects, and rather than comparison to once in a week, everyday GLPs they give you more side effects in comparison.
I don't think that's the situation.
That's the situation. So
Well, I will just counter JJ's point.
Yes.
Fine, I agree.
Which one? The GI side
GI,
effects?
so
But it happens though, you agree?
no, it happen. It is. It don't say that it's a side effect. It has to be. It's a universal side effect. This
is an
the
effect.
effect of the drug.
It is an effect
not
of the
a
drug.
Side effect.
Wait. When the effect is beyond a certain level, it's side
So
effect.
I'm coming to that point. No, that's the threshold. So that is called a threshold. What is called palpitation? What is the definition of palpitation?
More than 100, sir.
So no, that's not a definition by
No,
ECG.
no.
So that is a threshold. When somebody feels,
No,
it's called tachycardia, not palpitation.
not palpitation.
He has to go.
It is the
Palpitation.
it is the awareness of your own
That was
heartbeat.
the question asked to me in my
It is
physiological exam.
irrespective
At
of your
that
heart
point
rate.
of time, I was not aware. There is a difference. This is what I answered. The definition of tachycardia. So my professor said, no, this
yes.
is the definition of
No,
tachycardia.
question. It is the
You are
awareness
not
of
my
your
professor.
yes.
Anyhow, so the palpitation is the threshold where you feel that your heart is beating fast.
Yes.
It may be 67 for him
Yes,
and
yes.
120 for me.
Yes.
The similar side effect threshold is absolutely depending upon how much patient your educated is. So me, I was feeling nausea. I knew this will do it for me.
Yes.
I would not go and complain to Dr. J.J. Mukherjee, doctor, why you
Because
have
it
given
was
me drug?"
tolerable, you are fortunate.
So, but then I agree with you that there are few patients where you may have an intractable diarrhea, vomiting, etc. That's the point where we should be
generally,
careful and
Avdesh,
pragmatic. That
Avdesh,
I agree.
That's what I
Avdesh,
said. And
but
that's what I
then-
said. Don't just say it's a one. I mean, there are people who cannot tolerate it.
Yes.
Pancreatitis does happen.
Yes.
We should not put it on the carpet.
Yes.
The
No,
risk-
we are not trying to put it below the carpet for sure.
So the
but
message is if
No,
somebody.
sorry,
My
I don't
question
agree.
is simple.
Pancreatitis, no data.
My-
Look at
my-
all the trial.
my simple-
Again, the same issues
My
came
simple
up the
end
picture.
user.
You look at the
question, sir.
select trial, 4 year, you presented the data.
Yes.
You look at the evidence. What happened in the pancreatitis? There were more numerical number of pancreatitis in the placebo arm
Yes.
In
compared to
select- in
semaglutide.
select-
I
yes.
think this can go on, but one of the best methodologies to reduce down all these things which are there and the simple tricks are there on the screen, but a good interactive canvassing before you initiate and continuously briefing the patients about the possible effects of this drug will surely reduce down the GI related side effects, because this is probably a last question that I'll take.
This is the most important
And
question.
The most
Okay.
important question.
This we
and
can-
this is,
we can start a
yes,
debate.
This is the
AK
last
and I.
question that I'm going to take. Bansi, give me that 2 minutes of time. Last question that, and this is
अगर
as
समय है
usual.
तो आग लगा सकते हैं. अगर
Yes.
समय नहीं है तो
So, Avdesh, how SEMA is
So,
comparable
see,
to?
very simple. Let's not compare the two drug. I mean, this
you
is like
are supposed to compare.
I will come back. So let me start my, the introductory presentation. Then I will come to the hardcore
Debate में no
evidence.
introduction.
So first of all, for example, we don't wish to compare DEPA and IMPA. Both has got enough data. Now, when you are talking about GLP-1 and combined GLP-1 GIP, let's be upfront now that tirzepatide has got a upfront better body weight reduction data compared to semaglutide. There is no debate about that. Because we have got a head-to-head trial, Surmount 5, as you all know. Although again for the debate, it was an open-label trial. If Lilly would have been guts, they would have done randomized control trial. Would have saluted them. Why they didn't do?
They can't mix
If they
them up.
believe, why not? Then you don't claim superiority.
They
So
can't
in an
mix them
open-label
up.
trial, you should have done a double blind. Anyhow, but then I assumed that in terms of body weight reduction and HbA1c reduction, tirzepatide is better than semaglutide. How much? Now you might ask me, maybe 5% excess weight loss, maybe 0.5 to 0.6% better HbA1c drop. This data which we have. So that's one part of the story. But when you come to the other part of the story, which has got a better extra glycemic data, then answer is straightforward semaglutide. Semaglutide has got a cardiovascular data in people with obesity without diabetes, which tirzepatide don't have. Now, I would
Coming,
not
coming.
anticipate it will be positive. It's not GLP-1. Tirzepatide is a primarily GIP agonist, compounded with a GLP-1 activity. So outcome can go in any direction. We have to wait and watch.
Yeah.
You might, many people asking why you didn't take tirzepatide. Answer is very simple, because I am yet to watch for their cardiovascular safety data. 9 years has passed with for the Ozempic and Wegovy. That's why I am there for that, the molecule. And I did not want to lose 20 kg. That much I don't need it. Indeed, I stopped for 1 month because I was losing too much very quickly. So I stopped it. I don't want to go so fast. So see, if you have got a patient, say 140 kg, I have got my patients, those who have excess of 100, I put them on Monjaro. Those who are less than 100, this is my practical tips. I put them on Wegovy. Now when it comes to the data, MSLD
So
data.
more than 100, you're not worried about cardiovascular, liver?
So then I'm coming back to the part 2 of the story. Because there I want to lose more weight. Right? But if the 100 kg people has got established cardiovascular disease, then I would prefer semaglutide. So, see, now this will be presented through the same thing which I am telling you. So when it comes to liver data, cardiovascular data, heart failure data, I am more convinced with the semaglutide.
Kidney data as well.
Has to...
Kidney data as well.
Kidney data was there, so I'm not going to those data for the flow trial
Kidney
or
has come
sustained
in
data.
surpass CBOT now.
Surpass CBOT, again then it will be a criticism. Surpass CBOT is not a positive outcome trial. You did not win over dulaglutide.
Unequivocal, it's positive.
So it's non-inferior to dulaglutide.
Correct.
Remember,
But
you are not superior to
but
dulaglutide.
superior to placebo.
This
That's
is-
what SEMA is.
Huh?
It's superior to placebo.
Who?
Tirzepatide.
Tirzepatide is superior to placebo. Where did you conduct the placebo?
Putative placebo.
Not putative, not putative.
Not
Don't
putative.
assume
Not
Aishwarya-
numerical, not
so
putative.
putative placebo means believing that Aishwarya Rai is my putative wife.
Yeah.
You can't do it. Abhishek Bachchan will put you into a jail.
गलत example हो गया बहुत ये.
So thank you. Can I have a wonderful round of applause and standing ovation for this